the welcome to the stand. Dear Suri, who will be presenting on the potential impact of antiretroviral therapy on tuberculosis incidence amongst people with and without HIV in 26 countries, sub-Saharan Africa.
Good afternoon. Clinical trials and cohort studies have shown that antiretroviral therapy reduces the development of TB by 65%, irrespective of CD4 count. In the last decade, use of ART in sub-Saharan Africa has greatly increased. Increased use of ART could lead to substantial decreases in TB among people living with HIV. Our objective was to examine evidence of a population-level effect of ART by comparing trends in estimated TB case notification rates among people living with and without HIV during 2010 through 2014 in the WHO Africa region. Our hypothesis was that if scale-up of ART is reducing the development of TB, then TB notification rates should decrease more among people living with HIV than people without HIV. Since TB case notification rates stratified by HIV status are unavailable, we first estimated TB notification rates among people living with and without HIV using aggregate public data from WHO, UNAIDS, and UNPD. We also described trends in ART coverage from 2010 through 2014 using data from UNAIDS. Countries were included in this analysis if at least 75% of TB patients notified to WHO had known HIV status during at least 4 years from 2010 through 2014, and HIV prevalence estimates from UNAIDS were available during those years. After calculating TB notification rates, we excluded countries that showed greater than 50% year-to-year variation in estimated TB notification rates, suggesting either data quality issues or too few TB patients to make rate calculations meaningful. "22 countries met inclusion and exclusion criteria and are shown in pink on this map. This slide shows trends in TB notification rates by HIV status for Zimbabwe from 2010 through 2014 that we created by combining publicly available data. Zimbabwe is an example of a country included in our analysis where our expectation held true. TB rates declined more among people living with HIV, shown by the pink line, than among people without HIV, shown by the green line. Meanwhile, ART coverage, represented by the blue dotted line, steadily increased from 26% in 2010 to 51% in 2014. But we did not see this pattern in TB notification rates across all countries, as shown by this map summarizing declines in TB rates among people living with HIV compared to people without HIV by country. 15 countries, represented in gold on this map, show that TB notification rates declined more among people living with HIV than people without HIV. However, in nearly a third of the countries, shown in blue and mostly in West Africa, TB did not decline more among people living with HIV than people without HIV. So did TB notification rates decline more among people living with HIV than people without HIV overall? During this period, the median annual decline in TB notification rates among people living with HIV was 7%, compared to a decline of only 3% for people without HIV, and this difference was statistically significant. Therefore, if we take all the countries together, we see that, in general, TB rates have declined statistically more among people living with HIV than people without HIV. But is ART driving the declines in TB notification rates seen among people living with HIV? If it is, then we might expect countries with better ART coverage to have greater declines in TB among people living with HIV. We use linear regression to test this association. We evaluated the following predictors of change in TB notification rates among people living with HIV. Average ART coverage during 2010 through 2014, increase in ART coverage from 2010 through 2014. In addition to ART predictors, we evaluated the change in TB notification rates among people without HIV, which we used as an indicator of the quality of general TB control in a country. The last three predictors all relate to the trajectory of the HIV epidemic in each country, including HIV prevalence in 2010, change in HIV prevalence from 2005 through 2009, and years since peak HIV prevalence. Of the 6 predictors assessed for change in TB notification rates among people living with HIV, only 2 were significant independent predictors in multivariable analysis, and neither were ART variables. Instead, change in TB notification rates among people without HIV, which, recall, we used as an indicator of the quality of general TB control in a country, showed significant positive association, meaning that a decline in TB notification rates among people without HIV predicted a decline in TB notification rates among people with HIV. And HIV prevalence was a significant negative predictor, meaning that increasing HIV prevalence in a country predicted declining TB notification rates among people living with HIV. Of note, there was no interaction between HIV prevalence and ART coverage as predictors, and there was no collinearity among any of the evaluated predictors. Why didn't we see an association between ART and declining TB notification rates among people with HIV? ART affects TB notification rates among people living with HIV in contradictory ways. On the one hand, we know that ART reduces the development of TB among people living with HIV. However, ART also increases survival among people living with HIV and puts people in more frequent contact with healthcare systems, both of which could, paradoxically, lead to an increase in TB case detection, potentially underestimating the overall impact of ART on TB. In addition, ART coverage is not evenly distributed among the HIV population in each country. For example, if distribution of ART is prioritized among people living with HIV with lower CD4 counts in each country, then the preventive impact of ART on TB among people living with HIV might be underestimated, as these individuals are at higher risk of developing TB. Furthermore, if distribution of ART is concentrated in specific geographic regions within the country, then those specific areas might demonstrate a preventive impact of ART on TB, but such an effect might get diluted using national aggregate data. Third, trends in TB notification rates may not reflect trends in true TB incidence if case detection rates change between the years included in this analysis. This could either have under or overestimated the association between ART and TB notification rates. Lastly, adequate data were unavailable for over half the countries in the WHO Africa region, limiting the generalizability of these findings to the rest of the region. Our regression findings suggest that better TB control among people without HIV may produce greater declines in TB notification rates among people with HIV. This makes sense if we believe that most TB transmission is being driven by people without HIV, such that general improved TB control reduces the infection pressure on people living with HIV. The association between increased HIV prevalence and reduced TB notification rates may suggest that increased HIV prevalence is a proxy for another important factor for TB control, of which several variables can be considered, including funding levels, isoniazid preventive therapy, and others. In summary, our analysis shows that TB notification rates have declined more among people living with HIV than people without HIV during 2010 through 2014. However, the reasons for this relative difference are not only due to ART. Rather, these findings suggest the need for a comprehensive approach to reduce TB in the region. Despite not seeing a population-level effect of ART on reducing TB rates, the proven individual-level protective effect of ART makes it a critical part of a comprehensive TB control strategy, along with general TB control measures. Careful attention to the kind of variables collected and completeness of data collection can improve our understanding of the population-level impact of ART on reducing TB among people living with HIV. Thank you.
I think this is work. Can you guys hear me? We were so excited to get started. I think that we forgot to give you the overall name of this is obviously the HIV-TB Late-breaker session. My name is Amy Bloom, and I work at USAID, and this is Annabelle Bentley. If I said it, I never know how to pronounce that, from WHO. So we want to have a belated welcome to you here. So we thought what we would do, we have 6 speakers, and what we'd like to do is just 1 or 2 questions for clarification, and then hopefully have a discussion at the end. We know that many of these topics are very different, but we want to make sure that we give everybody his or her due, and so they're able to present. So if there are any questions for understanding of the actual clarification, well, we'll take those now. Otherwise, we'll have discussion a bit later. Okay, thank you very much. We'll go on to our next speaker. So our next speaker is Duncan Reed from Yale University, who will speak on high expression MIF alleles conferring protection against active TB. Thank you.
Hi. So the question is, do high expression MIF alleles confer protection against active tuberculosis? So HIV and TB co-infections are a problem worldwide, but are particularly acute in South Africa, where over 50% of new TB cases occur in HIV-infected individuals. If you look at a map of South Africa here with each province highlighted, this shows the HIV prevalence in percent, with the darker blue colors representing a higher HIV prevalence. And you can notice these dark blue provinces have over 25% HIV prevalence. Now looking at the number of TB cases per year, this year was 2005, we notice the same trend where the darker blue indicates a higher number of TB cases. I'd like to highlight the province of KwaZulu-Natal, which is the darkest blue in both of these maps. So it's really one of the epicenters of this TB and HIV co-infection. Zooming in on the province of KwaZulu-Natal, you can see Durban, Greytown, and Tugela Ferry, the 3 regions where we recruited patients. This brings us to macrophage migration inhibitory factor, or MIF. So it's a constitutively expressed pro-inflammatory cytokine, which is important in innate and adaptive immunity. So it mediates a number of cytokines, including a number of interleukins, TNF-alpha, and interferon gamma, which is well known to play a role in TB. So on the one hand, low MIF is a proxy for low inflammation, and it can predict better outcomes or lower risk factors for autoimmune diseases such as asthma and inflammatory bowel disease. On the other hand, you can have an infection such as meningococcemia, where inflammation is one of the main causes of the pathology, and actually having lower MIF levels and thus lower inflammation is actually beneficial. On the other hand, you can have high MIF levels, which also means higher inflammation, and this can lead to better outcomes or be a protective factor against it in terms of invasive pneumococcus, a salmonella infection, and in mouse models, TB knockouts of the MIF gene have actually shown to increase the burden of tuberculosis. TB studies have also been done with some HIV negative populations, but the data so far has largely been equivocal. So this brings us to the MIF gene, which codes for the MIF cytokine. So you can see here that there's 3 exons preceded by a promoter region, And the main important thing in this promoter region is a CATT repeat. The CATT repeat can vary from 5 repeats to 8 repeats. There's also a G to C single nucleotide polymorphism, which is in linkage disequilibrium with the CATT repeat. And the important thing about the CATT repeat is that MIF expression increases with the number of CATT repeats. So if you look on the x-axis here, this is the number of CATT repeats, and on the y-axis is the MIF gene activity measured here in luciferase units. And you can see that gene expression increases with the number of CATT repeats. Here we'll qualify CATT repeats of 5 being low MIF expressors, and anything with repeats between 6 and 8 as high MIF expressors. So this is a polymorphic locus, which has a global distribution of MIF levels that vary across populations. So if you look at the light blue here, the CATT 5 repeats are low MIF expressors, and the dark blue are CATT 6 to 8 repeats, which are the high. And I'd like to bring your attention to sub-Saharan Africa, which actually has a much higher prevalence, between 65% and 78% of these low-producing CATT 5 repeats, especially when you compare them to Caucasian populations in the US and Europe and East Asians. So the question here that we wanted to address was whether this increased frequency of low-producing CATT 5 repeats has any significance in the high burden of tuberculosis in sub-Saharan Africa. To address this question, we designed a study where we recruited patients from several sites in KwaZulu-Natal, South Africa. This included the McCord and King Dinizulu hospitals in Durban, the Church of Scotland Hospital in Tugela Ferry, and the Specialized TB Hospital in Greytown. So cases were all HIV positive, had microbiologically confirmed active TB, and also had a chest x-ray with signs of pulmonary involvement in the Durban population. Controls, on the other hand, were HIV positive, had an absence of TB symptoms, no history of TB disease, and had a chest x-ray without signs of pulmonary involvement, again in the Durban population. Blood was drawn and separated into serum for cytokine analysis. DNA was extracted for genetic sequencing. And all of this molecular work was conducted at KRIF at Durban and the Yale School of Medicine. So for the methods, we sequenced the CATT repeat, which is the functional allele, using small fragment analysis and microsatellite probes. We also quantified the G to C single nucleotide polymorphism, and we also measured MIF levels with ELISA. So our study populations were Durban, which was a more urban population, as well as Tugela Ferry and Greytown, which was a more rural population. And I'll just highlight the fact, demographically, the active TB groups and the control groups were all insignificant, were not significantly different, except for their CD4 T cell count. In the active TB group, it was significantly lower than the control group, both in the Durban population, as well as the Tugela Ferry and Greytown populations. In addition, the overall CD4 count in both groups in the Tugela Ferry and Greytown group were lower than in the Durban population. And this is because it's a rural population, so they present later in the course of disease. So the first question we wanted to ask is whether these polymorphisms are actually linked to a difference in the serum MIF levels. They've shown this in the lab, but we haven't shown this in an HIV-positive population. So our first results are that serum MIF levels do correspond to the genotype. So we calculated haplotypes, including the CATT 5 to 8 repeat that I mentioned earlier, as well as the single nucleotide polymorphism. And what we found is that the CATT 7C haplotype, which we would predict as being the highest expressor, had higher MIF expression than all other haplotypes within the Durban control group. As you can see here, the CATT 7C high has an average serum MIF level of 18.3 nanograms per microliter. So then the next question, once we've established this correspondence between genotype and MIF expression, is there any correlation between the polymorphisms that are low producers and actual active TB cases? And we showed here that low CATT repeats are actually associated with tuberculosis. So we have the active TB group here, as well as the controls. The light blue, again, corresponds to CATT5 repeats, which are low producers, and the dark blue corresponds to CATT6 and 7 repeats, which are the high producers. So you can see in the TB group, the percentages here represent the number of, the percentage of individuals in each group. Over 80% of the active TB cases had the low CATT5 repeat allele. If you compare this to the control group, where it was less than 70% of the individuals had this low expression allele. The odds ratio for this was a 2.2 with a significant p-value. So lastly, what we did was we compared the CD4 count with MIF levels. And we found a negative correlation of serum MIF levels with CD4 count. On the x-axis, you see CD4 cells per milliliter, and on the y-axis is serum MIF in nanograms per milliliter. And what we have here is a negative correlation with R-square value, which is small at 0.02, but was nonetheless significant. So in conclusion, the high expressor MIF haplotype, the 7 CATT repeat, with the C-SNP correlates with higher serum MIF levels. So this really shows that genotype can predict the amount of serum MIF produced. Secondly, in HIV-positive individuals, low MIF expressors, so the CATT5 repeats, are more likely to have pulmonary TB, suggesting a role of MIF in TB disease in this population. And this really agrees with the greater prevalence of low expressor, this 5 repeat CATT alleles in South Africa. And lastly, we had this unexpected negative correlation between serum MIF levels and CD4 count. So serum MIF levels may serve as a clinically useful biomarker of disease status in this population. So a lot of acknowledgements, particularly to the Yale School of Medicine, as well as all the Durban collaborators at CATT and the HIV pathogenesis program, as well as our funding sources. Thank you.
Okay, a couple of questions. Anybody? No? Okay, thank you. So we'll go to the next speaker. This is Robert Caro, who will be speaking on the immunological recovery on tuberculosis HIV co-infected patients on antiretroviral therapy, insight into strategy for tuberculosis preventive therapy.
Thank you very much. And my name is Basil Caron, Robert. We all know that HIV patients have high risk for tuberculosis, but we need to remind ourselves also this risk, including the patient who living in high-income country, not only people from Africa or like high-incidence settings. This patient also who receiving antiretroviral therapy or living in setting with low TB incidence have higher risk for tuberculosis. And the risk including the increased risk of reactivation of latent tuberculosis and the risk of progression to active tuberculosis from new infections. So for this reason, it's very important to think about tuberculosis preventive therapy. And the problem, who should receive the preventive therapy? As you know, WHO recommended IPT, for example, for HIV patients, but it's more like relative to high burden countries. For low incidence country, we need to have a target group, a population really at higher risk for tuberculosis. So some approaches say we look for patients with latent tuberculosis and we identify this patient with skin test or IGRA. Unfortunately, this doesn't work with HIV patients because the sensitivity is very low. Other approach, we can see it in other studies. They say, okay, we look for HIV patient at higher risk for tuberculosis, and we define this group by low CD4 cell counts at the baseline. The problem with this approach, we don't have agreement on the CD4 cell count as a risk, as a cutoff. And also, this approach doesn't take into account how the risk of tuberculosis change over time, especially when we have patients receiving antiretroviral therapy. And also, we're interested, we didn't find data about CD8 cell count and CD4-CD8 ratio as a predictor for TB risk. So we want to have like a new approach or like to look for a predictor for TB development. And for this reason, we analyze the immunological recovery in HIV-infected patients, and we compare patients who remain free from tuberculosis with the patient who developed tuberculosis through follow-up. And we mean by immunological recovery actually the trajectory, or some like literature call it the growth dynamic of CD4 cell count, CD8 cell count, CD4, CD8 ratio, and viral load. We use our data from the German cohort, it's called the CleanSurf HIV cohort, which is multi-center cohort for HIV clinical surveillance in Germany. For our study, we look for patients who, all these patients in our study were receiving combination antiretroviral therapy or HART. And we include over 10,000 HIV-infected patients who remain free from tuberculosis, and we have 144 HIV patients who developed tuberculosis during follow-up. For our study, was the starting point of our analysis was at the time at antiretroviral therapy initiation. And the last point was the TB diagnosis. That means we don't have any measurement. We were not interested to look what's happening after tuberculosis. We just look for what happened before tuberculosis. And we also exclude cases who has previous TB cases before the starting antiretroviral therapy. And also we exclude cases who develop other kind of AIDS-defining disease because we were interested in just developing tuberculosis. For our modeling, we use what's called multivariable fraction polynomials to look the best fit modeling, and we control for variables we have in our data, like sex, region of origin, drug abuse, age, and years of antiretroviral therapy initiation. This is our data. We show here that at the starting point is the time at antiretroviral therapy initiation, and here the TB cases happened after the HIV therapy initiation, and we can see from this the majority of cases happen in the first 3 months. And actually we exclude these cases because we think it's this case more likely to be unmasking active tuberculosis, which means these cases already exist, but was not subclinical due to the immune reconstruction inflammatory syndromes. So we exclude these cases and we focus on the happen after the 3 months. And as you see, the majority of cases happen during the 3 months, 3 years of antiretroviral therapy. Here we look for the trajectory of CD4 cell count. As you see here, the patient who remained free from tuberculosis, and this is a patient who developed tuberculosis during follow-up. And after the 3 months of antiretroviral therapy initiation, we can see that patients who remain from tuberculosis, they rapidly reach 400 CD4 cell count. And what we call like protective threshold, and for the same period of time, for the same CD4 cell count level, the patient who developed tuberculosis need almost 4 years. And during this time of period, we have like 70% of TB cases occur. When we look for trajectory for CD8 cell counts, we didn't find any significant difference between them. And as you see, the confidence interval was overlapping between two groups, and we didn't think it's like could help the protect tuberculosis in HIV patients. Then when we look for CD4, CD8 ratio, this is very interesting because the first data, as we know so far, look for the CD4, CD8 ratio as the predictor for tuberculosis. And again, after 3 months, the patient who remained free of tuberculosis, they reached 0.44 CD4, CD8 ratio. And to reach the same level, the patient who developed tuberculosis actually need almost 3 years. And this more reflect our data because the majority of cases happened during the first 3 years. And we believe this is very helpful marker for TB development in HIV patients, and which was neglected for many. When we look for viral load, we see we didn't find they always was HIV patient who remained from tuberculosis. They have lower viral load, but actually not really helpful in predicting the tuberculosis development. But this is also very interesting because it doesn't reflect what's happening in CD4 cell count. Because as you see, this was always because that also give support this give idea that suppression in viral load, it doesn't mean that's the recovery for immune system, and doesn't really reflect that the TB-specific immune system would recover. Here we try to look for other things. We try to look for what's happening close before the TB diagnosis. As you see, the TB diagnosis in like 90 days before TB diagnosis and 190. And we try to find if we can predict any decline in CD4 cell count before the TB diagnosis. Actually, we found a decline, but was not significant. And maybe this is due to our small sample size, and we don't really do many measurement at the end of TB, at the time of TB diagnosis. And actually, unfortunately, we couldn't do this the same thing for CD8 or CD4 CD8 ratio because we don't have enough data. So if I want to summary, we found strong association between development of active tuberculosis and antiretroviral therapy-induced response, basically for CD4 cell count and CD4 CD8 ratio. And we think this is a valuable marker for HIV-associated tuberculosis. And in our data, we found it could be defined as TB protective threshold is 400 CD4 cell count, 0.44 CD4 CD8 ratio. If we want to have conclusion in light of our finding, we can say if we start the initiation of antiretroviral therapy, because it's logical to wait 3 months to exclude unmasking tuberculosis cases, because we don't want to treat patients with active tuberculosis with monotherapy as preventive therapy. And we may wait 3 months after that, we could consider the preventive therapy for patients who remain under 400 CD4 cell count and under 0.44 CD4 CD8 ratio. And some patients, as we see, fortunately, they reach this exactly after the 3 months. Some patients, they under this protective threshold for a long time that make them at higher risk for tuberculosis. And then I want to thank everyone who participated in this study, basically my supervisor, Walter Haas, and the Professor Gerard Krause, and for everyone. Thank you.
Thank you very much for that presentation. Do we have any questions here for clarification? We have one at one, microphone one.
Thank you very much. Katharina Kranzer, also from Germany and from the London School. I just wanted to ask, I think it's a very interesting and important question, because obviously IPT for Africa and IPT for Europe are two very different things. But I think the important question for me would be, would it not be much simpler to actually look for where did the patients come from who had TB? If you find out that in that cohort, actually most of these patients were foreign-born patients and most of these patients were from sub-Saharan Africa, for example, rather than having complicated kind of thresholds, you might just say these people who come from high-risk TB prevalence areas are at much higher risk of having TB, and those are the people we need to focus on when we think about IPT in low TB incidence countries.
Yeah, actually, you're true. There's the majority, we can see the majority of TB cases in our data is originally from sub-Saharan Africa. But still we have German patients who born in Germany and also developed tuberculosis. And in our trajectory, we actually also control for the region of origin. That means it's we think it's these 3 holes that work for everyone in our data, because we control for this region of origin. If they're coming from sub-Saharan Africa or from Indian or from North America, it was controlled.
And did the patients get IPT at all? Did people do any TST testing or IGRA testing?
It's not implemented in the cohort. It's we have kind of recommendation in Germany, but actually when you talk with people from the cohort, they don't use it at all. Because the same idea about the sensitivity in skin tests, they say, oh, it doesn't work, why I should use it, and don't want to give. Actually, I get inspired from this study from talking from HIV conference, because I talk with the doctors every time about tuberculosis, they tell me why we should give in preventive therapy. We don't know if this patient have unmasking tuberculosis, we should wait, and if we wait, anyway, the immune system will be recovered. And so get this inspiration from this talk, I say, okay, we show them if you're true or not, and we have some patient who doesn't recover very well. Sorry, I said talking.
Thank you.
And at microphone 2, please.
Hi, Tom Wingfield from the University of Liverpool. Thank you very much for that talk. It was kind of an extension of that previous question, just because I couldn't see it from the talk about confounding factors. You mentioned about where people are from, but kind of socioeconomic status, whether people took drugs or alcohol, smoking, other things that can lead to problems with your immune system, that even diabetes, that might lead you to actually be more likely to have TB. I just couldn't see the confounders there.
Actually, in our data, we control for sex. We have sex, like we have age also. We control for drug abuse, if they're using like injecting drugs. If they coming from, if they originally from where, from sub-Saharan Africa, from America, and also we control for the time at the antiretroviral therapy initiation, because also we think it could be like interesting if the regime change and with the time we have like modern regime. Yeah, but for example, for other factors like income, we don't have this data.
Thank you very much. We'll go on to our next presentation by Andrea Howard from ICAP. We're going to switch gears a little bit and talk about an intervention package from the basic sciences. I'll let her.
Thank you. It's my pleasure to present this abstract on behalf of my co-authors. TB remains a leading cause of death among people living with HIV, accounting for nearly 25% of HIV-related deaths worldwide. Clinical trial data have demonstrated that early ART initiation during TB treatment improves survival amongst TB HIV patients. And the WHO recommends ART for all TB HIV patients within the first 8 weeks of TB treatment. However, implementation has been suboptimal. The START TB patients on ART and retain on treatment or START study aim to evaluate the effectiveness of a combination intervention package to improve early ART initiation and TB treatment success amongst TB HIV patients in Lesotho. Lesotho is a small, lower middle income country surrounded by South Africa with the second highest TB incidence rate and adult HIV prevalence in the world. Nearly 3/4 of TB cases are HIV positive, and in 2012, at the time of study start, only 43% of TB HIV patients were receiving ART. The START study was a 2-arm, mixed methods, cluster randomized trial. 12 health facilities in Berea District were randomized to deliver either the standard of care or the standard of care plus a combination intervention package after stratification by health facility type, that is either hospital or health center. In health facilities randomized to the standard of care arm, care was provided by nurses trained in the national TB guidelines. All TB patients were offered HIV testing by lay counselors, and ART was available to TB HIV patients in integrated clinics. DOT was provided by a treatment supporter who is designated by the patient. In health facilities randomized to the CIP arm, the combination intervention package was delivered to all TB HIV patients at regular clinical visits as part of routine care. Nurses working in the integrated clinics and village health care workers associated with the health facility were trained to deliver the intervention package and received ongoing mentoring by a nurse clinical mentor who visited the health facilities 2 to 3 times per month. The combination intervention package included programmatic, structural, and psychosocial components, including nurse training and mentorship in TB HIV co-management using a clinical algorithm which was available in the consultation room, reimbursement for transportation costs to monthly clinic visits for patients and their treatment supporter, health education for patients and the treatment supporter by a lead village health worker who is based at the health facility using a treatment literacy flip chart, and ongoing adherence support, which was comprised of automated SMS medication and appointment reminders delivered to the patient according to a schedule that they determined, as well as ongoing counseling from village health workers, both at the facility and in the community, to provide regular support. They contacted patients on a weekly basis and followed up with patients who missed their appointments. And in addition, patients were provided with airtime so that they could contact the nurse or a village health care worker in case of difficulties. Routine data were abstracted for all TB-HIV patients newly registered for TB treatment at sites between April 2013 and March 2015. Generalized linear mixed models were applied to test for differences between study arms for ART initiation and TB treatment success. And frailty models were used to examine difference in overall survival. All models included a random effect for study site to account for clustering of participants within health facilities in the study design. The characteristics of newly registered TB-HIV patients during the study period are shown here. Of the 1,233 patients, the mean age was 39 years, and 57% of the patients were male. 87% of patients had pulmonary tuberculosis, of which just over a third were bacteriologically confirmed, and 84% were new TB cases. Of 1,121 patients with available data, just over half had a known HIV diagnosis at the time of TB treatment initiation. And amongst these individuals, the median time from HIV diagnosis to TB treatment initiation was 582 days. Amongst those with a known HIV diagnosis, 50% were ART naive prior to the current TB episode. Almost all patients received cotrimoxazole during TB treatment. In a subsample of patients in whom we collected CD4 data, the median CD4 count at ART initiation was 151. And overall in the cohort, 30% were on ART at the time of TB treatment initiation. Amongst the 865 patients who were not on ART at TB treatment initiation, 96% of patients in the CIP arm initiated ART during TB treatment, compared to 86% in the SOC arm, with an unadjusted risk ratio of 1.12. There was no difference in ART initiation by age, sex, year, TB treatment category, or site of disease. In the CIP arm, 50% of the cohort had initiated ART 15 days after TB treatment initiation, and in the SOC arm, 25 days. And looking at the confidence intervals, you can see that over 75% of patients initiated ART within the WHO recommended time frame. Amongst all 1,233 patients, you can see treatment success here. In the CIP arm, 81% of patients achieved TB treatment success, compared to 73% in the SOC arm, for an unadjusted risk ratio of 1.11. Again, there was no difference in TB treatment success by age, sex, year, TB treatment category, or site of disease. All TB treatment outcomes for the entire cohort are shown here. You can see that in the CIP arm, 27% of patients achieved cure, compared to 17% in the SOC arm. Overall, 15% of patients died. The death rate was 12% in the CIP arm and 18% in the SOC arm. Here you see the cumulative survival probabilities by study arm, and in red you can see survival probability in the SOC arm, and in blue in the CIP arm. And as you can see, there was a 36% reduced hazard of death in the CIP arm, and this was statistically significant. So in summary, compared to the standard of care, with delivery of the combination intervention package, ART initiation was higher, time to ART initiation was shorter, and TB treatment success was more common. These differences were not statistically significant, but the risk differences between study arms were substantial, 10% difference for ART initiation and 8% for TB treatment success. Furthermore, the START combination intervention package significantly improved survival of TB-HIV patients. Timely HIV diagnosis and ART initiation are essential to mitigate the high mortality associated with HIV-related tuberculosis. I'd like to acknowledge the contributions of the START study team, in particular our study participants, the staff at the study sites, and the village healthcare workers in the surrounding community. In addition, I'd like to acknowledge the collaboration with the Berea District Health Management Team and the Lesotho Ministry of Health, and our funding from PEPFAR and USAID. Thank you.
Thanks very much for a great talk. Has anybody got any questions?
Ken Castro, Emory University and USAID. Andrea, thanks. Nice job. I'm wondering what's the added cost for achieving the comprehensive package over the standard of care? Because that you're showing a marginal benefit there. Is the juice worth the squeeze?
Yeah, it's a very good question. We actually did collect costing data as part of this study, and I don't have the numbers right in front of me. I'll tell you that some components of the package were very, very inexpensive. Putting a village health worker at the health facility, very low cost. The automated SMS system, about $100 to $200 a month to deliver the SMSs. The transport reimbursement was $1.40, and the airtime was $3.70 per patient, so less than $5 a month. So a lot of the components of the intervention, obviously the training materials, the job aids are already available and are very easy to print and distribute. So a lot of them were relatively cost efficient, I guess you would say.
Okay, microphone one.
Hi there, Lisa Cranmer from Emory also. Thank you very much for a wonderful presentation. I was curious about the clinical mentoring aspect, if you could describe a little bit more how that occurred, and also if you had any metrics around it in terms of the time spent and over time. Did that decrease over time during your intervention?
Mm-hmm. It's a very good question, thank you. So we did collect a lot of process data on sort of delivery and uptake of the various intervention components, and again, we haven't fully analyzed those data, but we had a nurse that was working part-time on the project who visited the health facilities roughly 2 to 3 times per month, and that the intensity of those visits sort of varied over time. As in many other settings, there was considerable healthcare worker turnover at some of the sites, so a site that might have been functioning well for a period of time might have again needed more intense mentoring if there was sort of a changeover of staff that needed sort of on-the-job training and mentorship. And some sites experience more challenges than others. So it did vary, but I think that mentorship component was extremely important component of the intervention.
Okay, thank you very much. Last
Jerry
question.
Friedline from Yale University. That was wonderful. So the hardest endpoint, which is survival or mortality, was achieved, and the ones that you measured weren't. So can you speculate as to what unmeasurable variables might have actually been going on that contributed to the survival benefit?
Yeah, so it's a really good question, obviously one we've talked about a lot, I think that the whole is the sum of the parts, and it's not all about initiation, and it's not all about, completion, but you need both in order to improve survival. And I imagine that there were a lot of spillover effects that happened from the mentoring. I mean, we were really focused on a particular point on the care cascade, from the time of you were already diagnosed and starting treatment to that 6-month mark of treatment, but probably overall care and maybe improved diagnosis or time to diagnosis might have improved as part of spillover. And we could see that, bacteriologic diagnosis of TB, for example, was higher in the CIP arm as opposed to the SOC arm.
You think there might have been a component of social support that was added by the village health workers?
I know that was absolutely, that was such a crucial part of the intervention, was the village health worker support, the fact that they called patients or went to their homes on a weekly basis, sometimes accompanied patients to the clinic. The fact that there was a lead village health worker at the health facility who sort of provided supervision and really was the glue that made sure that there was a continuum of care between the facility and the community. And they had monthly village health worker meetings at the health facility where they discussed difficult cases with the nurse. And that was really an important component of the intervention. And from the qualitative data, we know that it was very valued by patients and providers.
Is there qualitative data that might actually
There are. We
that?
had a whole qualitative component, and that will be forthcoming. Yeah.
Okay. Thanks. Thank you very much. So I'd like to welcome to the stand Rebecca Chang of CHI, who will be speaking on community-based TB screening and HIV testing for ex-minors in Lesotho.
Hello, good afternoon, everyone, and thank you for the opportunity to present today on behalf of CHI, Mine Workers Development Agency, JPIGO, and the National Tuberculosis Program on a project that took place earlier this year, where we conducted community-based TB screening and HIV testing, specifically with the ex-mine worker population in Lesotho. This was a pilot project, but the largest effort to reach this population at the community level in Lesotho. So I'm going to just skip some of this context that Andrea already gave on Lesotho, but specifically focusing on the section on the mine worker and ex-mine worker population. So we estimated that the total population of miners and ex-miners in Lesotho probably makes up around 5 to 10% of the total population. They're considered a key population under the 90-90-90 strategy, especially the second 90 that focuses on reaching 90% of the key populations. And according to the most authoritative study on this population, which the data was collected in the early 2000s, it estimates there's around, the TB prevalence rate in this population is around 9 times higher than the general population. And also the HIV prevalence rate is a little higher as well. So our project, we started actually our work in 2014, and in 2014 we conducted focus group discussions with this population. We were looking specifically to assess health challenges faced by this population, but had a specific component looking at barriers to TB diagnosis services, and these are some of the gaps that we identified. So on the diagnosis side, no targeted activities for this population, poor knowledge of TB by the population, and poor health-seeking behavior in general. On the treatment initiation side, even when minors or ex-minors were diagnosed with TB, we found that there were significant economic barriers to access facilities. So specifically, they talked about not having transport funds to reach the facilities. High mobility of minors was considered a major barrier, and also inconsistent community-based follow-up once diagnosis results were available. So our project really sought to build our response in a very tailored way to respond to these gaps that we identified in our assessment in 2014. So our project took place across 5 districts in Lesotho. You'll see on the map here the 42 sites where we conducted TB screening and HIV testing services, and our project took place with 3 partners. So CHI was responsible for a lot of the design and overall coordination, as well as the reporting and technology aspects. JPIGO was our main clinical partner, and we also worked with Mine Workers Development Agency, which is an organization that has a lot of experience, several decades of experience working with the ex-mine worker population in Lesotho. They're actually the development arm of a miners' union, and they were responsible for a lot of the local authority and target population engagement, as well as the general outreach management. So I wanted to highlight 2 aspects of our work that we thought were particularly successful in resulting in high yields at our events. So first is the community mobilization strategy, and then I'll talk a little bit about the mHealth aspects of the project as well. With our community mobilization strategy, this was developed together with Mine Workers Development Agency, and as I mentioned, they have a lot of experience working with this population in Lesotho. And so they had around 5 different components. First, they identified hotspot cluster areas using a beneficiary database that they had already. So they had a very extensive database with all around 17,000 ex-miners in Lesotho, and we were able to use that to really see where there was a high density of ex-miners and where we could concentrate our efforts. The second aspect was sensitizing and engaging local political and traditional leaders who really helped a lot with the mobilization efforts. We marketed our events on local radio stations. We conducted door-to-door mobilization and also at local restaurants and pubs, and we made calls to the MDA beneficiaries who are within that database in these areas. The second aspect that I wanted to highlight is the mHealth aspect, and I think one major point here is that when you're working at the community level, especially providing screening and testing services to large numbers of people, we found that having electronic data was very key to being able to troubleshoot very readily and do some course correcting. And so this mobile data collection, we thought it resulted in high quality data, the troubleshooting, as I said. And one other aspect I wanted to highlight was that it was very key for allowing for standardized application of the TB and HIV testing algorithms and protocols that we used. And so because the counselors and the nurses are using the application to guide those processes, it makes sure that there is pretty strict adherence to those algorithms and protocols. It was also very helpful with follow-up when we were doing follow-up household visits and also follow-up on lab results to ensure that we knew exactly who we needed to follow up with and had that data very readily available. So moving on to our results, first on the registration side, so we were able to register a total of 7,000 individuals over a course of 6 months, and these are specifically people who attended the events. Our project target was 6,000, and of the participants, 85% were ex-miners, and around 15 ex-miners and miners, and then 15% were family members of those individuals. Our participants, 87% were male and 13% were female. And specifically looking at the ex-miner population, this is really a population that has worked primarily in South Africa, and so 96% have worked in the gold mines. The average age is 63 years. They worked, the average years of service in the mines was 22 years, and virtually everyone had worked primarily underground. And underground work experience, this is a significant factor because of higher rates of silicosis and TB, specifically in the underground miner population. On our TB screening results, so of the 7,000 who were registered at the events, we were able to assess 88%, of which 86 of the 88% was eligible for TB screening. Those who were ineligible were either currently on TB treatment or awaiting TB lab results. Of those who are eligible for screening, only 0.3% declined to be screened, and then we screened around 5% as having TB symptoms, and 95% as not requiring further evaluation for TB. Of those who we followed up with, 63% were able to submit sputum on the spot, and then of the 37% who weren't able to produce sputum on the spot, around 60%, we were able to follow up at home and collect that sputum. And so in total, we submitted lab results for 235 individuals, and we had a 94% result return rate, and diagnosed 12 patients with TB and initiated them on treatment, so a 5% positivity rate in the lab results. On the HIV testing side, so HIV testing coverage was similarly high among those who attended the events, and resulted in around 2,800 people being tested for HIV. So again, we had 27% of those registered as being ineligible for HIV testing, either because they were already diagnosed with HIV or they had been tested in the past 3 months. Of those who were eligible for HIV testing, 75% consented, and among that 75%, 5% tested positive and 95% tested negative. So in total, we diagnosed 139 individuals with TB, and 76% were initiated on care. I just quickly wanted to highlight the results in a slightly different way, and this specifically is looking at adherence to testing guidelines. So in Lesotho, the National HCC guidelines recommends that all adults be tested for HIV every 3 months. And if you look at our group pre and post intervention, so this is excluding individuals that we didn't collect the HIV status for, which is around 1,200 of the 7,000 that we registered. If you exclude those and just look at those that we collected the HIV status for, you'll notice that only 32% met testing guidelines before our intervention among those we evaluated. So it was 21% were HIV positive, or 11% had been tested in the past 3 months, and then post-intervention, 24% were HIV positive, and 59% had been tested in the past 3 months. So in conclusion, I just wanted to highlight some factors that could be taken into consideration if this approach was scaled up to other populations or geographic areas. First was that engaging community leadership and partners was very, very critical to our mobilization efforts. Second, having epi data and up-to-date landscape information on partner activities was very helpful for informing targeting and avoiding duplication of efforts. Having a patient-centric design, and especially the assessment that we conducted earlier in 2014, was very useful in knowing specifically how to target the ex-mine worker population at the community level. And the mHealth tools really helped to improve overall coordination and oversight of the project. Thank you.
Thank you very much, and this paper is open for questions. We've obviously changed a little bit from the clarification because it makes more sense to do it this way, but we'll have a few minutes at the end for those who had questions for earlier presentations as well.
Rebecca, thank you. I was wondering, among those ex-miners who screened negative for TB, are they being offered treatment for latent tuberculosis? Because it would seem to me that this is a very high-risk population. You're showing me a rate of over 6,000 per 100,000 population.
Sure.
They're, 99% of them worked for 22 years underground. I would say my guess is silicosis is almost universally present in those.
Yeah, and silicosis is around 25% according to that study that I quoted earlier, but it's not in the national guidelines, and our project was very much using the national guidelines to guide our testing and treatment strategy.
Jerry?
Thank you very much. That's really very commendable work in a population that's very neglected. So it puzzles me also, as Ken mentioned, that this population was as healthy as you found. And I wonder if you had any information on pre-study morbidity in this mortality rather in this population. That is, had larger numbers of people who had worked in the mines for this long period of time, exposed to TB and silicosis, actually survived or died before the study, and you have selected a population of survivors.
We don't have that data. I will say, specifically on the TB results, that's something actually, our yield rate was something that was very surprising to us as well. And I think, one thing is that, in comparison to the study that we were looking at that took place in the early 2000s, and when we were seeing ART coverage in our population, 90% of those who were diagnosed, who were HIV positive, 90% were already identified pre-intervention, and 94% of those were already on ART, and so we thought that had something to do with it. I think another factor is that we were only using symptom screening, and there was a study by Gavin Churchyard showing that incorporating chest x-ray screening in this population increased their yield by 2.5 times, and so I think that was also another factor there.
Thank you.
Thank you very much. Our last presenter is Mamata Biswas from the Union in India, who will also be talking about accessibility to HIV-TB services and screening of TB among PLHIVs.
Good afternoon, everyone. I would be presenting a short case study from one of the districts of central Indian state, Madhya Pradesh. I work in Madhya Pradesh with the union as a technical consultant, advocacy, communication, and social mobilization to the state government. My research question and assumption, the research study that we did was basically to assess the accessibility, how accessibility to services can reduce the proportion of cases lost for TB screening amongst the PLHIVs. That was our assumption. And based on that, our research question was, what are the facilitators and hindrances for TB screening amongst PLHIV presumptive TB cases that are referred in the state of Madhya Pradesh? Coming to the background of why we took up this particular case study and why we took up this analysis, in India in 2015, the HIV prevalence was estimated as 0.26%. And if we see the TB HIV burden in India, the incidence is estimated to be 2.8 million for 2015 as per the WHO Global TB Report 2016. And if we see the TB HIV load, that is 113,000 to be estimated for 2015, and reported figures are available for 2014, that is 44,000 approx. The mortality amongst the HIV TB load is 37,000, which is estimated for 2015, and the reported figures are about 5,800. In this scenario, Madhya Pradesh contributes about 2% of the HIV estimates in the country. The national policy in India states that there has to be an intensified TB case finding in HIV care settings as well, which includes prioritized offer of expert services to all PLHIV presumptive TB cases for early diagnosis of TB as well as for rifampicin resistance. However, this is a one-year data of Madhya Pradesh, which reports that amongst the referrals from ART center to the TB, 24% only have been tested on expert, and out of which 5% have been diagnosed as TB. So there's a huge proportion of cases being missed, and we wanted to assess or explore what are the reasons for these cases being missed. Madhya Pradesh is a province of central India, having a population of 79.1 million, mainly residing in the rural areas, and only 30% is residing in the urban cities. Madhya Pradesh is providing TB services through 244 TB units and 812 designated microscopy centers. There are 18 ART centers in Madhya Pradesh, so the co-location status is about 72% in the state. We have expert services available in the state since March 2014 at 6 sites, and since this year, April, additional 29 sites have become functional. So this particular case study is from the district Sagar, which has been providing expert services to the district as well as to the division since March 2014. Sagar district is located in the north-central Madhya Pradesh. It is bordering to the neighboring state of Uttar Pradesh. It has a population of about 2.6 million, again mainly residing in the rural areas. But Sagar district also has about 9% tribal population. Sagar district is divided into 8 blocks, providing TB services through 8 TB units and 24 designated microscopy centers. ART center is located at the district headquarters at Medical College in Sagar district. This ART center is catering to the administrative division, entire administrative division. Actually, Madhya Pradesh state is divided into 7 administrative divisions, out of which 1 division is Sagar division, which is covering 5 districts with a population of about 8.6 million. The expert services have been available in the district headquarters since March 2014. Since January 2014, expert is catering to the district itself. Prior to that, it was catering to the entire division. We used a combination of both qualitative and quantitative research. We did record reviews through the cross-referrals and line lists from both TB and HIV. In-depth discussions were done with healthcare providers at both TB and the designated microscopy centers as well as the ART centers, as well as with the beneficiaries, that is the PLHIVs who are accessing the services. The qualitative responses were, the narratives were documented using content analysis. Now coming to the results, if we see in 2015, Sagar district, 455 PLHIV presumptive TB cases were referred from the ART center for TB screening. However, out of these, only 65% have been screened for TB. When we discussed with both healthcare providers and PLHIV beneficiaries, there were multifold responses that were revealed from the in-depth discussions. The healthcare providers felt that the presumptive TB cases which have been referred for TB screening, they are lost or missed, perhaps due to the distance or the accessibility issues, which was also concurred by the PLHIVs. But there were other responses with the healthcare providers felt, that is, the cases referred are not willing because of the stigma associated with TB, or there was a low felt need amongst the PLHIVs, or they perceive that they're not suffering from TB. So that may be the reason that these TB cases, the presumptive TB cases, are not reaching for accessing the services. However, the PLHIVs, on the other hand, they felt that the attitude of the health staff was not proper, and as well as the distance was inconvenient for accessing the services. So that was the reason that these people were not reaching for accessing the services. As I mentioned earlier, in 2015, this is a 12-month data, January to December, 455 referrals were there from ART center to the for accessing TB services. However, 65% were tested by expert and 6% were detected for MTB. Meanwhile, there were two short interventions done in between. This was towards the second half of December. One is the co-location of HIV and TB services in the same premises. A microscopy center was initiated within the medical college premises in December 2015. This was facilitating the collection and transportation of sputum samples to the expert site. As well as the second intervention was where the health staff were trained on soft skills for counseling of the presumptive TB cases. The result was that the next 5 months data, when we analyzed, it was like the cases which have been tested by expert and are increased to 94%. Out of 109, 103 have been tested through expert. So there's a drastic reduction in the number of cases or the proportion of cases which were lost with this intervention. So we see that with this, the cases which were earlier actually lost, which was reported as 35% in 2015, this 6-month data analysis shows that it has come down to 6% from 35%. And post this, we also again spoke to the PLHIVs as well as the healthcare providers. So the in-depth discussions also concurred that the improved accessibility has actually improved the patients, the cases lost has come down because of the improved accessibility to services. Coming to the conclusion, yes, of course, the importance of co-location of HIV and TB services is important. There's also a need for ease of access to HIV and TB services, as well as need for patient-friendly services, so that the patients are not, the presumptive TB cases which are referred, they do not have fear in accessing these services. There is a need for strengthening supervision and linkages between HIV and TB services in this district, as well as there's a lot of importance is, there's a need for an improved counseling so that the demand for HIV-TB services is generated amongst the intended population. That's it from my side. Thank you.
Thanks very much, very interesting. Anybody got any questions? Okay, microphone.
Yeah, I'd like to find out about the MIF, and was wondering if there's any signal that there could be a relationship between MIF and the degree of severity of TB or the extent of TB.
Yeah, that's a good question. We have some data of outcomes, but we don't have that much. And we collected a lot of clinical data, but in terms of like grading the severity, we still have a ways to go, so we don't have a very good idea. We were just doing pulmonary TB. I think one of the thoughts we had was to see disseminated TB. We actually do have another cohort that was focusing on TB meningitis, and that actually showed a stronger signal as well, so. A subtype, but it's a good question, and I think that's the next step in this project.
And then while I'm up, could I ask another one, please, about the miners in Lesotho? I'm wondering if there's some sort of survival bias that these guys are relatively old, they've survived a long time without TB, and possibly they're more robust than their colleagues who succumbed.
I think it's very possible, and yeah, I think maybe a lot of what we're seeing is the healthy worker effect there. I mean, some of the men who are coming into, I mean, we know they're all men who worked in the mines, so obviously they're physically fit, and yeah, the average age is 63 years, and so I do think we are seeing some of that effect there.
I think that was, I just want to comment on the last presentation. I think that was very interesting. One of the things that always strikes me when we see this is not just accessibility, but it's something you learned when you were very little, which is if you're nice to people, they'll come back. And it seems that we have to learn this over and over again, that how we treat patients makes a big difference, or individuals who come to clinics. I mean, I think it was very interesting to hear about the co-location, and then it seems the increased number of expert, but it seems that also the humanness of it also, from what you were saying, seemed to make a difference. And I didn't know if you had been able to tease out any of those different qualities, or if there was any of the workers, the healthcare workers, had any insight into that.
Yeah, while we were talking to the healthcare providers, which included even the staff, not only the medical officers, we also spoke to the different levels of healthcare providers, including the lab technicians, the supervisors, the treatment supervisors, as at the ART centers as well as at the designated microscopy centers. Yes, initially the healthcare providers did not perceive their attitude to be a hindrance in the amongst the hindrance in accessing services by the PLHIVs. However, when post intervention, when we again spoke to them, they also concurred on the same thing. Yes, with the soft skill training, the improvement in the number of cases that are being tested has gone up.
Yeah, this is for the MIF talk. I think I heard you say that low MIF levels were correlated with more TB as well as low CD4 counts. Is that correct?
Yes.
But then I also thought you said that there was an inverse correlation between MIF and CD4 count.
Yeah. That's
so
true.
that seems like a discrepancy.
It seems like a counterintuitive, yeah. No, so thank you for the question. I think that's a good point, and it's one of the challenging things with this MIF is that you have a risk factor where you have these polymorphisms, which are predictive of the basal production of MIF. But depending on the severity of the disease, the serum MIF levels can vary. So what our thought was with this inverse correlation is that with these low CD4 counts, you have like acute even immune suppression. And because of that, you have maybe a compensatory effect with the MIF. But I do agree that it's a complex thing. They're not always aligned, and it's because of the acute disease states in which patients are in.
You want to go to a mic? I'll ask a question in between, but no, please go. And this is for Andrea. I was wondering if your equivalent, your sort of control group, the SOC, if you thought that group was indicative of most people and the services they received, or if that cohort was actually pretty good comparatively, and so wondered if that might be one of the reasons why you saw less of a large difference.
So thank you. That's a good question. And obviously, there were temporal trends, and obviously services improved, art uptake particularly improved over time, I think throughout the country. But when you look at the results from this study in this district compared to the national data, it definitely was a better performing district than some of the other districts. And I think Dr. Mama said she wished all her districts did so well. So there probably was like a Hawthorne effect just because we were doing the study and we were observing, and that did improve somewhat. Yeah.
Thank you. Jerry? Just was filling in with my question.
So, thanks for the opportunity. So I just want to expand on Duncan's comment. So MIF, as he showed, is responsible or highly correlated with a number of autoimmune states where MIF uncontrolled, in a sense, produces an adverse effect. And we weren't expecting to find this. It's never been looked at in relationship to HIV and CD4 count. And the immunosuppression in HIV might actually, going on at very low levels of HIV, might result in unopposed MIF, actually high levels that might ordinarily be modulated. And therefore, MIF becomes a bad rather than a good thing in that circumstance, in that it may, in fact, result in autoimmune or other phenomena or cytokine storm that results in actually part of the seriousness of disease with low CD4 counts. So all of that has to be sorted out. It's just an unexpected observation that I think is very tantalizing in terms of the role of this particular genetic composition and how it can both be of benefit and also of harm depending upon the clinical circumstances in HIV disease.
Well, if I don't see any other hands oh, we have one person. Yes, come on down. This will be our last, and we will be closing the session afterwards.
Thank you. My name's Vivian Cox. I work for DRTB Stat. My question is for the minor in Lesotho study. I'm a firm believer that we need to take HIV services, including testing and TB screening, into the community like you did, and so I think that's wonderful what you were doing. I was just curious, when I was with MSF in KwaZulu-Natal, we struggled a lot with linkage to care once the patients tested positive or needed further screening and treatment for TB. Did you support linkage to care for the minors, and how did you measure that to ensure that they made it to the nearest health facility?
Sure, yeah, linkage to care was a big part of our project, and so there were a few mechanisms we used to encourage linkage to care. For the TB patients, it really wasn't a challenge, and we diagnosed 12 cases. It was very easy. They were all willing to be initiated on treatment, and we actually gave mobile money payments in the amount of something equivalent to a transport voucher, so around $3 US, for those who presented at the facility. And so on the TB side, it was very straightforward. On the HIV side, it was much more difficult, and I think you'll see up there that we linked 76% within the first 2 months, and we found that with those patients that there was a need to have a lot of dialogue at the family level, and so a lot of them didn't want to come to the health facility right away. Even when we did home visits, actually, a lot of times the healthcare workers were turned away at the door. But one mechanism we did find to be very helpful was actually direct accompaniment. When we did HIV testing at the cluster area, we would then ask the newly diagnosed HIV individuals if we could accompany them directly to the health facility that day. And we found that from that there was actually an uptick in linkage to care. And so maybe they had less time to think about family implications or something, but we did see that improvement.
Well, thank you all for coming to the 4th year of our HIV-TB Late-breaker session, and hope to see you next year as well. And please get your abstracts in. We had great abstracts this year, and these were the best of the best. So I want to thank all of our panelists here, and have a good afternoon.